My name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 3 of this respirology series, where today we're going to be covering acute asthma. And if you haven't seen parts 1 and 2 of this respirology series, make sure to check them out before you watch this video. So with all that being said, let's get straight into it. Okay, so let's do a quick recap of some of the clinical features of asthma. So we know that asthma is variable sporadic airway obstruction in response to particular triggers. So if the asthma is severe, this can reduce alveolar ventilation, which can lead to blood hypoxemia, so a lower concentration of oxygen within the blood. And therefore, the body responds to this by increasing heart rate and breathing rate. And clinically, this is it's going to present as tachycardia and tachypnea. During expiration, positive pleural pressures squeeze on the airways, leading to airway obstruction. Okay, so particularly during forced expiration, when we think about exercise as being one of the triggers of asthma, okay, the intrapleural pressure can become positive. So that's relative. So it's more positive relative to the pressure within the alveoli, within the airways, and hence causing that airway collapse because the intrapleural pressure should never exceed the intraalveolar pressure. Okay? But when we have the diaphragm pressing up on the parietal pleura during forced expiration, that leads to that increase in the intrapleural pressure. Okay. So we also have some gas being trapped in the alveoli, leading to lung hyperinflation. This can present as episodic dyspnea. You know that dyspnea, you're probably well aware that this means, shortness of breath. Patient must contract their expiratory muscles more forcefully to effectively try and rid the air from the lungs. And this can present as chest tightness. Patients might report that they almost have like a band-like tightness across their chest. Narrow airways lead to turbulent airflow. So turbulent airflow movement through the airways. This can be heard on auscultation as a polyphonic expiratory wheeze. Okay, so it's a sound heard on expiration, and polyphonic means that there's lots of different sounds. Okay, and during severe attacks, there's use of accessory muscles to increase the thoracic volume, and an increased airway obstruction leads to the lungs taking longer to empty. Okay, so we have visible contraction of the scalenes and sternocleidomastoid muscles. We also have this prolonged expiratory phase of breathing, okay, because it's taking longer for the air to be expelled from the lungs. And the function of the scalenes and sternocleidomastoid muscles, they function to increase the intrathoracic volume. Okay, so the sternocleidomastoid elevates the sternum, and the scalenes elevate the upper ribs. So let's just recap some of the investigations in symptomatic patients, so in acute asthma exacerbations. So during an asthma attack, we have mucus plugs within the bronchioles in the alveoli. So there's going to be a reduced airway lumen diameter. And then during expiration, positive pleural pressures compress the airways, like I previously mentioned. So this is going to result in a forced expiratory volume, FEV1, less than 80%, and an FEV1 over FVC ratio of less than 0.7. And that's going to be on spirometry or pulmonary function testing. And then we've also got constriction of the airway smooth muscle, which can further contribute to a reduced airway lumen diameter. And then in symptomatic patients, we can stimulate their airways with a SABR, which is known as the bronchodilator response test, which you'll be familiar with if you've watched my previous video. And then the smooth muscle is going to be responsive to the SABR. So we could sometimes see 15 to 20% increase in the FEV1. Also, we're going to have reduced alveolar ventilation. So we're going to have a mild decrease in the partial pressure of oxygen, lead to hyperventilation, and result in a respiratory alkalosis. So this present with hypoxia and hypocapnia. Okay. And it's important in acute asthma in particular, we want to basically keep an eye on the CO2 because a normal or a high CO2 suggests that the patient is getting tired and they're ventilating less, which can lead to respiratory failure. Okay, so that's something very, um, you should definitely be aware of in acute asthma, and that's why they do subsequent um, arterial blood gases to keep an eye on that PaO2 and PaCO2. Okay, so now let's talk about the grading of acute asthma in adults. Okay, so when we have moderate asthma, this is going to be a peak expiratory flow rate between 50 to 70% of their best or their predicted value. Okay, and they're going to have some increasing asthma symptoms. Okay, so that episodic dyspnea, chest tightness, etc. In the severe category, there's a PEFR of 33 to 50% of the best or predicted values, a respiratory rate of greater than or equal to 25 breaths per minute, pulse greater than or equal to 110 beats per minute, and the patient might have an inability to complete sentences in one breath. So things to be aware of, when you first go and assess the patient, are they able to maintain a sentence? Okay. And then we have life-threatening. This is when we have a PEFR of less than 33% of the best or the predicted value. Oxygen saturations of less than 92%. Silent chest. Okay. When they can't, failing to expel that trapped air. They could be cyanosed. Okay. So make sure to check the peripheries and also centrally under the tongue. We might have a poor respiratory effort, low blood pressure, a low heart rate, dysrhythmia, and they might even be confused, exhausted, or be in a coma. Okay, so all things to be aware of. And then we have near fatal acute asthma. So this is where we have a raised partial pressure of CO2 requiring mechanical ventilation with raised inflation pressures. Okay. So this is quite a high yield part of the video, particularly when we look at the some of the life-threatening features. So these are regularly things which come up in exams, so it's important that you take note of these. Okay, so now let's talk about the stepwise management of acute asthma. Okay, and we're going to take an A to E approach. Okay, but if any time the patient loses consciousness or there's no signs of life, you want to put out a crash call and consider starting CPR. So let's talk about the admission criteria first. So this wants to be for life-threatening asthma and severe asthma unresponsive to treatment, and other criteria such as a previous near-fatal attack in pregnancy, and then attacks occurring despite the use of oral corticosteroids, and attacks which occur during the night. Next, we have oxygen. Okay, so this is following the use of the arterial blood gas, which quantifies the degree of hypoxia. We also want to sit the patients upright, okay, so they can basically try and expel that trapped air. And we can consider starting 15 liters of oxygen via a non-rebreather mask, okay, and this can be titrated down when the patient is able to maintain their saturations between 94 to 98%. Next, we have a short-acting beta agonist, and this is going to be high-dose salbutamol. Also, sometimes they use terabutylene. And in moderate asthma, they might use a pressurized metered dose inhaler, okay, plus or minus a spacer. They're the pretty standard inhalers what are used, okay, so it has a a standard dose of the medication which the inhaler is able to deliver into the lungs. Okay, and then in more life-threatening acute asthma, they might consider the use of an oxygen-driven nebulizer. Okay, they can give roughly 5 to 10 milligrams per hour. Okay, and then we have corticosteroids. So we tend to use 100 milligrams of hydrocortisone. Hydrocortisone is given intravenously, or the equivalent of prednisolone would be 50 milligrams. And the earlier the steroids are given, the better the outcome tends to be. And then we have something called a SAMA, so we have a short-acting muscarinic antagonist. Okay, so such as ipratropium bromide, and this is when a patient doesn't respond to a SABA as we would like, and we can even use a combination of nebulized salbutamol and also nebulized ipratropium bromide, so a nebulized SABA and SAMA combined. Okay. Next, we have magnesium sulfate, which has bronchodilator effects because it blocks the influx of calcium into the bronchial smooth muscle. Typically, we give intravenously 2 grams over 20 minutes. Okay, and at this point, you will be wanting to think about some senior input. Okay, and we also have another drug here called aminophylline. Okay, which is a phosphodiesterase inhibitor. It's also an adenosine receptor antagonist, particularly A2B adenosine receptors. And essentially, this prevents histamine and leukotriene release. But it does have some side effects because there are a type of adenosine receptor called A1 receptors on the heart. And one of the side effects, because of the action on these A1 receptors, can be cardiac arrhythmias. Okay. And this tends to be initiated by senior medical staff in a critical care context. So someone who's very familiar with the use of this drug. And we don't particularly tend to use antibiotics. We don't particularly tend to use antibiotics unless there's evidence of underlying infection. And if all this fails, and the patient will likely be in critical care at this moment, senior doctor might consider the need for intubation, okay, and invasive ventilation. And then in terms of monitoring, we want to be checking the PEFR every 15 to 30 minutes, pre and post salbutamol. Want to try and keep the oxygen saturations above 92%, okay? And then we want to be doing these consecutive arterial blood gases. We want to keep a close eye on the partial pressures of oxygen, the partial pressures of CO2. Okay, remembering about the warning signs when the partial pressure of CO2 is normal or potentially elevated. And then you might want to do some bloods as well because salbutamol can induce low potassium, known as hypokalemia. Okay, and that can lead to problems with the heart, such as arrhythmias. So all things to be aware of. Monitoring is particularly important. So let's just briefly touch on the management of acute asthma following stabilisation of the patient. So we want to optimize their long-term asthma management plan, and the patient tends to continue 40 to 50 milligrams of prednisolone orally for 5 days. The patient wants to have their own self-written asthma management plan. They might have a rescue pack of oral steroids, and we want to consider referral to a specialist if they've had 2 attacks in 12 months. Okay? So I hope that helps to simplify acute asthma. Thank you very much for watching. Stay tuned for the next video where we're going to be talking about an introduction to chest X-ray interpretation. Something I'm very excited about teaching, so make sure you keep an eye out for that. But with all that being said, take care, have a nice Christmas, and I'll see you in the next video.